pathology. The lesions of cystitis are usually unevenly distributed over the bladder. Indeed, in many acute or mild chronic cases, the lesions are entirely confined to the neck of the bladder and the trigone. This so-called inflammation of the neck of the bladder is commonly due in men to some prostatic inflammation, which latter must be attacked in order to cure the, quote, inflammation of the neck, end quote. It may be noted here that in every cystitis, whether acute or chronic, the prostatic urethra, and in women, practically the whole urethra, as well as the bladder is inflamed, and the vesicle inflammation is most intense about the neck and the trigone, unless some special feature of the disease, tumor, stone, pouch, produces a distinct focus of more intense inflammation elsewhere in the organ. Acute cystitis. At first, there is a sharp congestion, most marked about the trigone and the neck, or entirely confined to that region. The mucous membrane is swollen and bright red in color. The capillaries are dilated, the epithelial cells swollen. Then the epithelial cells begin to desquamate. The angry crimson of the mucous membrane is blotched by petechiae. Its gloss is lost, and here and there vesicles or superficial abscesses appear. After these break, minute ulcers remain. If the acute condition persists, the muscular and peritoneal coats may become infiltrated, interstitial cystitis. Chronic cystitis. The mucous membrane is irregularly thickened and dense. Its surface is rough, red in color, perhaps mottled by purple or brownish blotches left by submucous hemorrhages. There may be areas of ulceration and granulation. Sometimes the granulations grow to be distinct little villosities several millimeters long. The ulcerations may extend deep into the substance of the organ and communicate, rarely, with abscesses in the muscular tissue. In long-standing cases, the epithelium may become cornified in spots, the superficial epithelia being replaced by dense, shiny scales resembling the horny layers of the skin, leukoplakia vesicae. The ulcers may be coated with adherent phosphates. Cystitis cystica and cystitis granulosa, see page 371, are perhaps the result of chronic inflammation. Gross changes in the wall of the bladder. In prolonged chronic cystitis, the wall of the bladder becomes thickened or thinned, its cavity contracted or dilated, its surface thrown into folds of mucous membrane overlying irregular interlacing bands of muscle fiber. The resulting changes are described as hypertrophy, thickening, or atony, thinning of the bladder. Hypertrophy of the bladder may be concentric, cavity contracted, or eccentric, dilated. The irregularities in the bladder wall are spoken of as trabeculae, trabeculated bladder, or diverticulae, sacculated bladder, page 538. Diverticulae extend through the entire thickness of the bladder wall. They are often congenital. Trabeculation occurs in all cases of prolonged chronic cystitis. Microscopic changes in the bladder wall. The microscopic changes in the muscle of the bladder afflicted with chronic cystitis have been shown by Czekanowski to be almost purely sclerotic, whether this muscle be thick and apparently hypertrophied or thin and manifestly atrophied. When apparently hypertrophied, the increased thickness of the bladder wall is only due in very small degree to actual muscular hypertrophy. It is chiefly due to inflammatory infiltration and sclerosis of the muscle, as well as of the interstitial tissue between the bundles of muscle fiber. The so-called hypertrophied bladder may be as feeble as the atrophied bladder. The hypertrophy is a false hypertrophy. The various degrees of hypertrophy and atrophy are due to the interplay of inflammation and retention. If the retention is slight or absent and the inflammation severe, the bladder undergoes concentric hypertrophy. If retention is marked and inflammation severe, eccentric hypertrophy results. If retention is marked and inflammation mild, dilatation and atony result. Pericystitis. The changes that occur in the connective tissue surrounding the bladder are usually of a protective character. An intense chronic cystitis often provokes a thickening of the perivesical tissue and of the peritoneum. Less frequently, a diffuse fibrolipoma occurs, comparable to the perirenal fibrolipoma, and, like it, protective in character. In such cases, the fibrous masses may often be felt through the rectum, and I have known them to be mistaken for cancer of the prostate until cystotomy showed the prostate to be normal and the whole bladder to be thickened. When there is much pericystitis, the bladder is usually found in a state of concentric hypertrophy with fibrous, undistensible walls. Suppurative pericystitis is usually due to trauma. Abscess. Abscess of the bladder is rare. Small abscesses of the mucous membrane may run their course unnoticed. Abscesses within the wall of the bladder may begin in some infected interstitial focus or in a pocket of the mucous membrane. They burst into the bladder, leaving deep necrotic pockets, which may continue to suppurate indefinitely or lead to perforation. Purulent venous thrombosis has been seen. Membranous cystitis. Exfoliation of the mucous membrane, partial or complete, may occur as the result of an intense cystitis or of trauma. It is rarely seen except as a complication of prolonged and difficult parturition or as a post-mortem finding in patients who have died septic.